I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation's educational webinar series. I'm also a patient living with MPA vasculitis, and today we'll be following up some questions about GCA that were not answered in a previously recorded webinar. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we would like to thank our sponsors, AstraZeneca, Amgen, and Novartis, for supporting these webinars. And we're grateful today to have Dr. Sebastian Unizani back with us to answer some questions about GCA. So welcome, Dr. Unizani. It's great to have you again today.
Well, thank you, Kathy. So it's a pleasure. I love to be part of this initiative. I love to help as much as I can, answering questions, doubt, educating, again, as much as I can.
Well, and thank you so much, because we did have some that were left over from the last webinar, and we always try to promise our patients that we'll get back to it and get the answers. So I'd like to start by introducing you today. Dr. Sebastian Unizani is an assistant professor of medicine at Harvard Medical School. He co-founded and co-directs the Massachusetts General Hospital Glomerulonephritis Center and the Rheumatology Vasculitis Program. One of his research interests is finding better treatment options for patients with giant cell arteritis, GCA. As such, he has ample experience designing and conducting investigator and industry-sponsored clinical trials in GCA. So I am officially welcoming you and asking you if you have any disclosures before we get started today.
I usually provide consulting for different companies. At the moment, I'm doing consulting for Sanofi. I've done consulting for other companies. I have helped companies design clinical trials, but I don't think those conflicts would influence the answers I will be providing today.
Okay, and thank you for letting us know that. And I'm going to just start right in with some questions from patients that hopefully you can answer and clarify for them. And the first one is, what eye exam can identify early signs of restricted blood loss that could lead to optic nerve damage to intervene in order to prevent vision loss?
Yeah, so unfortunately, there's no such a test that is used commonly in practice. So far, there's active research right on the topic. It's super important. At the moment, the way we do this is we teach and discuss with patients what are those symptoms that should make them act immediately. And then every time we see patients, we are very careful on the questions we ask and the physical exam to try to identify those signs or symptoms that might be predicting impending vision loss, and I can mention them in a second, but there's no single test or blood test or ultrasound or anything that you can do routinely in someone that is feeling fine that will tell you, yes, this patient is at risk and you should be doing this or that. If a patient is having visual symptoms, so what we usually say, okay, be very careful, pay attention to any episodic changes in your vision. If you all of a sudden you have blurry vision, more if it's one eye only, but it could be both, it has to be episodic, you are seeing fine, and then all of a sudden there's blurriness, or all of a sudden there's like a black curtain coming down the eye, especially if it comes and goes, right? It gets better, it gets worse, right? Over minutes or hours. So that's very, very important to be aware of. If there's double vision, also episodic, all of a sudden you start seeing double. And obviously, if a patient stops seeing and the vision is not coming back, those are episodic blurry vision, episodic double vision, or the absence of vision. So we usually say if any of these 3 or 4 things happen, you must have 80 milligrams, 60 milligrams. It depends. Different providers recommend different dosing, but it's usually a high dose of prednisone, 60, 80 is usually the norm. Take it right away and go to the nearest hospital. That's the plan we create. Patients need to know that vision loss is usually an early event. I think we covered this in the prior webinar. 95% of patients that lost vision, that happened initially, mostly when the disease wasn't diagnosed or hadn't been diagnosed, because once the patient is receiving treatment, that risk decreased dramatically, and having vision loss on follow-up is not impossible, but is a rare event. So that's part of the answer. If a patient is having visual symptoms, we suspect that there is involvement or compromise of the eye. Then when the ophthalmologist does a fundoscopic exam with this ophthalmoscope, they dim down the light and they look in the back of the eye. There are some signs that are that could reflect decreased perfusion of the optic nerve, right? This optic nerve that is usually sharp will be pale, the margins will be blurry, it will be enlarged. There's a classic picture of an optic nerve that is suffering from ischemia or low perfusion. But in a patient that is asymptomatic, you could do a fundoscopic exam and most likely that will be normal. The second test that you can do when there's signs and symptoms of optic nerve involvement nowadays, and this is under research, hasn't been established, it's not routinely done, is an MRI of the orbit. We got to know in the last few years that patients having ocular involvement will have some changes, or not all of them, but many of them will have changes on the MRI, some structures that are around the optic nerve. Sometimes the periphery of the optic nerve itself will uptake contrast. But again, we are not doing those type of MRIs in patients that are asymptomatic, so we don't know how good either the fundoscopic exam or the MRI could be to pick up those patients that are at risk. That hasn't been explored in detail. Another test, and this is the end of the answer, is, and again, it's for patients that are having the symptoms of ocular involvement, is the so-called fluorescein angiography, usually done in the ophthalmology office. They inject some contrast and then they take pictures of the back of the eye, and then when there is ischemia or low perfusion, there are some characteristic changes. Usually the back of the eye gets filled with blood, and that gives you a characteristic image. And when there's impairment of the flow, there are patchy areas of no perfusion or less perfusion. Long story short, we still rely on careful assessment and monitoring of signs and symptoms, and the field is working hard in identifying a test, maybe an MRI, but still we are not able to do that routinely to anticipate vision loss.
Well, thank you for that very thorough answer. I tell you, it'd be comforting to me as a patient to know that as long as I'm being routinely cared for and seeing my provider, that I'm not as likely to have that happen if I'm in treatment and being cared for. So that was a very great answer with all of the information that I think we need. Thank you so much. And the next question is, can GCA spread into the aorta or femoral arteries?
Yes, so the answer is yes. GCA is the most common large vessel vasculitis, so by definition involves the large arteries. Those are the aorta and the main branches. The main branches are the ones that go to the neck. We call them carotids, subclavians, and then going down, the aorta divides in the iliac and then the iliacs become the femoral arteries. So yes, most patients with GCA will have some degree of involvement of the large arteries. The most commonly involved arteries are the aorta, maybe 60%. You can do an image, an MRI or a CTA or a PET-CT, and you'll see that there's involvement. And the other common arteries are the subclavians and the axillary arteries, right? The arteries that go to the upper extremities. In GCA, we make the distinction between arteries that could be involved when you do an image, right? Versus that involvement that will become clinically significant, meaning there's going to be 60%, 70% of patients that you do an image and you see involvement, but most of them, that involvement won't become clinically significant. Clinically significant means that the aorta becomes dilated, right? We call that an aneurysm, or that these subclavian or axillary arteries shrink, and then patients have symptoms from low perfusion. So that would be around 15, 20%, 30% in some cases. So it's more common to have radiographic involvement than clinically significant involvement. But when there is radiographic involvement, we like to follow that over time to make sure that the patient doesn't become a patient with clinical involvement, if I may say.
Very interesting to know the difference between those two things. Thank you for clarifying that. The next patient says, I have aortic vasculitis, and my daughter was diagnosed yesterday with LVV and possibly GCA. She's 31. Is that too young for that diagnosis?
Yeah, I think it is too young. I don't have all the details of the case, but usually, by definition, right, GCA happens in patients 50 years or older. Rarely we see a patient that is slightly younger than 50, 49, 48, 47. I think GCA in someone that is 39 will be very, very, very rare. If there is evidence of arterial inflammation in the locations that we are talking, aorta, subclavians, in the locations that GCA may target in this age group, I would think about Takayasu arteritis, which is a disease that commonly happens in younger patients. And then there are some other rare types of large vessel vasculitis. So I think GCA.
I was going to say, is the other part of the question says LVV? I'm not sure what that is, but is that also, is it young for that also?
Yeah, so I would have started by saying vasculitis is divided in the size of the vessels involved. The LVV, or large vessel vasculitis, the two most common are giant cell arteritis and Takayasu arteritis, and there are a few others that are very, very rare. So this patient seems to have large vessel vasculitis, LVV, but is young, is 31, so by definition will be very, very unlikely to be GCA, and perhaps if it's truly LVV, perhaps it's Takayasu arteritis. But I recommend rediscussing the case with the treating physician to make sure.
Go back to your provider, because Dr. Unizani is not your provider. But thank you for the great advice and answer to their question. You know, the last time we did a recorded webinar with you, or the webinar that we had before on GCA, you covered a lot of trials that were in the process. And I'm just wondering, are there some results from some of those? Could you give us a short update on any of those?
I can, yes. The most exciting one, if you remember, there was a study called Select GSA. It was a phase 3 study. Those studies that are done in a larger population of patients to try to confirm that a medication worked for a disease or rule it out. So that this study called Select GSA compared a medication called upadacitinib. The commercial name is Rinvoq, and the study was designed in a way that it had 3 arms. One arm had a higher dose of upadacitinib plus 6 months of prednisone. A second arm had a lower dose of upadacitinib and 6 months of prednisone. And the third arm, the comparator, was placebo, right? No active medication, and 12 months of prednisone. So there's been a press release a couple of months ago, or 2-3 months ago, showing that the results are positive. There's a little, we haven't seen the paper yet, but it has been presented in conferences, and 49% of the patients receiving this higher dose of upadacitinib and 6 months of prednisone met the primary endpoint, that was being in remission for an entire year, versus 29% of those assigned to placebo and 1 year of prednisone. So it's very exciting to see that the study was positive. Remember, there's only one FDA drug approved for GCA at the moment, it's tocilizumab. We also use a lot of prednisone, and we sometimes use the medication called methotrexate. So we are eager to add medications to our toolbox, and hopefully this will be the next one. We'll see.
So what does that exactly mean to patients? Is it because some people don't tolerate tocilizumab very well, or is it just a new, better possibility for some?
Yeah, so the example I like to give is rheumatoid arthritis. So if you search the medication, you Google rheumatoid arthritis, you'll see that there's, I don't know, 13, 14 different options. And these diseases are complex, and the pathways in one patient might be different to the pathways of disease in another patient. So not every patient, for example, coming back to GCA, not every patient will respond to tocilizumab. There's I don't know, 30%, 20% may relapse on tocilizumab. Another 10, 15% may need to stop tocilizumab because of a side effect. So you need alternative for those patients. And this one might be one.
Well, that's exciting.
Yeah. Yes, and the other quick updates are there was another study that I mentioned, phase 2 preliminary study with a medication called guselkumab. So that study completed enrollment. So now we need to wait for the patients all the patients to finish, and then the results to be analyzed. And then there's another study that is also a phase 3, very important, with a medication called secukinumab that also completed enrollment. So now we need 1 year from the last patient enrolled to start seeing those results analyzed and published. Remember, there was a phase 2 study with that medication called secukinumab that was positive. So this phase 3 is hopefully to confirm that the medication works for a number of patients.
Okay, and is there anything about, I hope I say this right, abatacept? Did I say that right? Abatacept?
I think abatacept, we commented on a preliminary phase 2 study, again, that was encouraging and positive, and a second study was planned, but I'm not sure how far that second study is enrollment-wise.
Okay, well, great. Thanks for updating us on that. It's always exciting as a patient when you learn that there are new options available to you and possibly improvement of life and dealing with our disease. I actually have a few questions for you because PMR often comes up when we're talking about GCA. So could you just give us, me, the layperson, an explanation of PMR?
Yeah, so sometimes it can be a bit confusing, and you'll understand why. So PMR is an inflammatory disease. Sometimes it's defined as an arthritis and periarthritis of the shoulders and hips, meaning it's going to inflame not only the shoulder and the hip joint, but the structures around. Patient can have bursitis or tendinitis around the true shoulder joint or hip joint. So arthritis and periarthritis is the second most common inflammatory disease after rheumatoid arthritis. Patients present with pain and stiffness in the shoulders and hips. The classic story is that the pain and stiffness happens after immobilization. So when they wake up in the morning, right after sleeping for a few hours, they wake up, they are very achy, very stiff, they cannot raise their hands. And after an hour, 2, 3 hours, upon moving, that stiffness, the pain gets better. If they're driving for an hour to come to see the doctor, when they come off the car, again, they are for 15, 20, 30 minutes, very achy, very stiff. That's the inflammatory pattern of shoulder and hip pain. It's different from pain that is mechanical, pain that is not present when you wake up and is present with some movements, rotator cuff disease or osteoarthritis. Those patients will have more pain. The more they do, the more it will hurt. It's the opposite. But anyway, PMR, described like that, is called primary PMR or isolated PMR. Those patients don't have anything else. They don't have GCA. That's their disease. So that is the second most frequent inflammatory disease after rheumatoid arthritis. period, right? That's one thing. Patients with GCA can also have PMR symptoms. We call that PMR secondary to GCA. So 40%, 50% of patients with GCA, on top of maybe having headaches or jaw pain or scalp tenderness, they can also have PMR symptoms. But that's in the setting of GCA. So primary PMR, the patient that doesn't have anything else, is 3 times more frequent than GCA. And that's my computer that sometimes when I move does things. So that's the brief explanation of PMR. There was another question that asked how often a patient with PMR can progress and develop GCA. Yes. So the answer is not that often. So if your disease starts as PMR, most likely it will remain PMR. There's like maybe 10 or 15% may progress to GCA, but most of them will stay in the PMR spectrum. And the other important thing to keep in mind is that for some people, PMR and GCA are the ends of a spectrum, right? The milder end is PMR, and the full-blown, more severe end is GCA. The reason why I kind of agree. We think that way is because the epidemiology is exactly the same. It's usually elderly patients, women a little bit more than men, more often Caucasian or white, although it can be seen in other races, but the epidemiology is very, very similar. And the treatment response is also similar. Remember that this molecule called IL-6, that is an inflammatory marker that is very important in GCA, and is the one that tocilizumab blocks. Seems to be important in PMR as well, and there's a medication that is not tocilizumab but is very similar, and it's called sarilumab, that functions also blocking this IL-6, works for a number of PMR patients. So there's many similarities.
So is there a new study or treatment underway for PMR also, do you know, or is it just mainly what we've been talking about as GCA?
Yeah, so PMR is taking off in the last few years in terms of clinical trials, which is great. Up to very recently, the only option was prednisone. The good news is that people need less prednisone than GCA. Remember, GCA is usually started on 60 milligrams or 40 milligrams and then taper. PMR is much less. People only require 15, 20, 25 sometimes. So the exposure is less, but still that exposure to prednisone can create problems. The treatments are, like in GCA, several months, 1 year, sometimes more. And historically, there were not many other options, maybe methotrexate in some patients. But recently, as I mentioned a minute ago, there's a medication called sarilumab that is FDA approved after an international multi-center clinical trial. And there are some trials ongoing. One is with this other molecule that I mentioned for GCA called secukinumab. Because the diseases belong to the same spectrum, there's some rationale suggesting that the same medication could potentially be useful in both GCA and PMR. But yes, there's sarilumab and there's clinical trials ongoing.
Okay, thanks. And I was just thinking about what you said, that GCA can have PMR as a secondary, but usually PMR doesn't progress to GCA. But I'm just wondering, are there big risk factors with PMR? I mean, if you don't get it diagnosed early, can it get progressively worse if it's not treated?
No, the good news is that PMR is not a dangerous, it's an annoying condition. Nobody wants to have PMR because being aching and stiffness obviously impairs your functionality. People develop fatigue. It's obviously an annoying disease, but it's not dangerous. So people don't get vision loss. So it's a more benign condition to have. something that is evolving to make things a little bit more complex, the way rheumatologists like, is nowadays we are seeing in the last few years actually that a percentage of patients with PMR, you do those imagings we were talking about in GCA, those imagings of the arteries, the CTAs or MRAs or PET-CTs, and what we are seeing for a number of years is that, I don't know, 15, 20, 30% of patients that clinically they have PMR, that's it, they don't have GCA clinically, but they will show changes similar to GCA in the arteries. So the question that we haven't answered yet is, what do we do with these patients? Because clinically they are behaving like PMR, but the image is showing features of GCA. Do we give them the lower dose prednisone? Do we give them the higher dose? How do we follow them? And that's evolving. There's still not an answer. But we are paying more attention, or obviously when we discover that there's some inflammation in the arteries, we follow that over time. But again, still there's no clear guidelines on how to treat those patients, and also whether we need to image all the patients. Do we need to image every patient with PMR? So there's active research across the world to try to answer that.
Okay, and we've been talking about the eyes and vision loss so much in this, and one patient asked, what is a neuro-ophthalmologist? How do they differ from an ophthalmologist in terms of managing their GCA?
Yeah, so for managing the GCA, neuro-ophthalmology and ophthalmology are equivalent. So if you have an ophthalmologist, be happy, continue to follow with that person. If you have a neuro-ophthalmologist, too. So the neuro-ophthalmology is this specialty or discipline that combines knowledge from ophthalmology and neurology, right? They focus on those diseases, neurologic diseases that can impair vision or cause vision problems. They get involved into GCA because, remember, GCA in 10, 15, 20% of the patients will cause impairment in the flow of the arteries that feed the optic nerve, and that will lead to vision loss, right? Optic neuropathy or damage of the optic nerve. So that's why neuro-ophthalmologists may get involved. But an ophthalmologist is also well equipped to monitor patients, do the exams, those fundoscopic exams we were discussing initially. So it's just one more step in the specialization, if I may say, of a doctor. Oftentimes there are ophthalmologists that completed some extra training in neurology, or the other way around. I don't know, I hope that answers the question.
Oh, it does. So as far as your GCA is concerned, stick with who you have because you're confident in both of them. So that's great news. Also, one last question. Could you explain VEXAS syndrome? This patient has said that they read that VEXAS syndrome can be similar to GCA.
Yeah, so to try to make it simple, VEXAS is a relatively new disease. It's a genetic disease. There's a mutation in a gene called UBA1 that leads to the disease. And the clinical manifestations belong, if I may say, to two different worlds. So there's inflammatory rheumatologic manifestations and hematologic manifestations. So the hematologic manifestations are usually decreasing the blood cell counts. Those patients may develop anemia, they may develop a drop in the number of white blood cells or platelets. Those are the blood cell counts. Many of them require transfusions because the anemia is significant enough. If you do a bone marrow biopsy, those precursors or some precursors of these blood counts will have characteristic changes or vacuoles. So that's the hematologic part of the syndrome, and then the inflammatory rheumatologic part. And that is variable. Most of the patients have this syndrome that we call relapsing polychondritis, or something that is very similar to relapsing polychondritis with inflammation of the cartilage The classic location is the ears. Some other syndromes that this patient can have. One is called Sweet syndrome. Patient may develop fevers and characteristic types of rashes in the skin. And then a minority may develop a syndrome or a disease that looks a lot like GCA. So it's not that all patients with VEXAS will present GCA symptoms, but a percentage, perhaps a small percentage, may. So it's a disease that is new, and now we are all recognizing that some patients that were difficult to characterize, many of them ended up having VEXAS, right? Now we have the ability to test for the gene, so we are finally solving some mysteries of patients that historically have been difficult to understand.
Well, that is very interesting, and I'm glad you clarified that for all of us. And I do want to just thank you today for spending your time with us, Dr. Unizani. We appreciate the follow-up on the questions, because there are always more questions than we can get to when we do the webinars. So thank you so much for that. And we'd like to thank the Vasculitis Foundation for just providing these webinars, medical webinars for us, and our sponsors, of course, Amgen, AstraZeneca, and Novartis. So thank you again, Dr. Unizani. We greatly appreciate your time.
My pleasure. Thank you for the invitation.